Afternoon, all doctors. On behalf of Science Integra and Bharat Serums and Vaccines Limited, I welcome all doctors to the TOG webinar on RH negative pregnancies. Today, we have an esteemed faculty line of many doctors from across Gujarat who will be having a case discussion on RH negative pregnancies. Today, I'm privileged to introduce to you Dr. Sheetal Punjabi. Can I have the next slide? Who is the convener for the program today? Dr. Sheetal Punjabi is a MD Gold Medalist Radiologist and IVF Specialist from Cleveland Clinic, USA. She has been practicing IVF for the past 22 years. She has been a visiting faculty at various national and international forums with a keen interest in academics. She has been keen on providing preventive health care to the needy people and mental well-being for the old and abandoned individuals. Dr. Sheetal Punjabi is working towards those goals via Shashwat Foundation and various other NGOs. Dr. Sheetal Punjabi owns the Sheetal Nursing Home and has been a gynecologist since 1997 to 2002 at Khambat, and the director since 2002 of Shashwat IVF and Women's Hospital, Ahmedabad. And Dr. Sheetal Punjabi has also been a partner from 2015 till today of Midas Touch Cosmetic and Skin Care Center. I welcome Dr. Sheetal Punjabi and I request Doctor to please take over the proceedings of this webinar. Thank you.
Thank you very much. At the outset, let me thank TOG and Surat Society for conducting this extraordinary program. I thank Bharat Serum and Vaccines for being the partner for this program. We have like a group of experts of fetal medicine with us today, and we are going to throw light on RH negative pregnancy. And for this, Dr. Jayesh Patel, who is President Surat Obstetric and Gynec Society and a consultant fetal medicine and IVF specialist with us. And I really thank Dr. Jayesh Patel for taking on this initiative and partnering with us in this. Dr. Jayesh Patel, who is running a Parnu IVF Center at Surat, has been the organizing secretary of Surat Gynec Society in 2011 and 2017. He has got 2019, in which he was zone proxy. He has got Gujarat Gynec Excellence Award. So, like, you know, as a person of like very high excellence is with us today with a team of experienced panelists. He has been the South Zone representative in SOBOG in 2012 and 13. SOBOG, that is state organization of all gynecologists and of Gujarat. This center, like this Parnu, is Foxy recognized center for ultrasound training, and in that he has trained more than 100 gynecologists in ultrasound, and he has trained more than 20 gynecologists in IVF. So that's really great, as he has done his fellowship under Dr. Suresh at Chennai in 2010. Definitely he can, like, you know, train a lot of the junior doctors, and that's really great. He's also, like, you know, same as me, like he has studied from Municipal Medical College, and he has done his MD and DGO same way from VS General Hospital under Dr. Behram Ankleshwarya. Other than all these activities, excellent that he is also doing some social activities along with the Rotary Club. He has been the president of Rotary Club of Adodra in 2009, and he is president of Uttar Gujarat Mitra Mandal, Surat, since 2008. So I welcome Dr. Jayesh Patel to further proceed with our program. Thank you very much.
Thank you, Dr. Sheetal, for this nice nice introductory words. Uh, in this era of Anuja, can you stop sharing your screen so that I can share my screen? Okay. In this Corona era, sharing the knowledge has become very easy with the webinars, and I like this platform very much because in the last few months we have done so many webinars with various societies of the Gujarat. In fact, without Sobok conference or Foxy conference, we were not able to meet so many friends. But now, with the help of webinar, we create new friends and we meet so many friends online. થોડી મજા જે પર્સનલી મળવાની હતી એટલી નથી આવતી બટ meetings are now getting very regularly. So coming to my topic today, management of RH negative pregnancy. Today's flow of program is that first I will take the lecture and then Dr. Darshan will take over for the panel discussion. Some basic idea about the RH negative pregnancy management I will take, and then we will also see the management of the complications. Coming to the causes of the fetal anemia, they are commonest is the RH isoimmunization, then parvovirus infection, in monochorionic pregnancy, TTTS or TAPS, that is twin to twin transfusion, or twins anemia polycythemia sequence, where the donor will be the anemic twin, or in case of feto-maternal hemorrhage, fetus might have anemia. We will stick to RH isoimmunization and not the other conditions. Among the RH in the Spain, the highest incidence of RH negativity is noticed, which is around 30%. In Asia, it is 2% or even less. Basics about this blood grouping, all of you must know since our first MBBS days. ABO system and RH system. ABO is A, B, AB, and O. While in RH it is C, small c, D, E, small e, and G. Small d is actually there is no antigen, but it is the absence of D antigen is denoted as a small d. Fetal RH antigen develops at 7.5 weeks of gestational age, that is 30 to 40 days after the fertilization. And minimum fetal blood which can cause sensitization is 0.1 ml only. And the genes for D antigens are located on chromosome number 1. Here is how it is inherited. If mother is RH negative and father is RH positive, then if father is heterozygous, that is one copy is having a RHD gene, in that case 50% fetus will be RH negative and 50% will be positive. So in this pregnancy, 50% chances of getting RH negative fetus, and that's why there is no chance of isoimmunization. But when father is homozygous, that is carrying the two copies, then all the fetuses will be RH positive, because positive is a dominant factor. How the feto-maternal hemorrhage comes into action. That is, yeah, the amount of fetal blood necessary, it is, as I have already shown, that it is minimum 0.1 ml. Studies have suggested that up to 30% of the person with RH negative blood never develop incompletely, even when challenged with large volumes. That is their natural or genetic tendency. And alloimmunization occurs by one of the two mechanisms. That is, one is the incompatible blood transfusion accidentally, and another is a feto-maternal hemorrhage due to positive fetus in negative mother. The feto-maternal hemorrhage may occur during pregnancy or after delivery. That is 10% chances during antenatal period and 90% are at the time of delivery. So fetal RBC have been detected in the blood in all three trimesters. That is, in first trimester there are 7% chance, in second trimester 16% chance, and in third trimester there are 29% chances of getting the RBC into maternal blood. The initial maternal response to this positive RBC coming from the fetus, they are IgM antibodies. So they are larger molecules and they cannot cross the placental barrier. So initially there will not be anything going to happen to the fetus. But within 6 weeks to 6 months, IgG antibodies are formed and they remain in the maternal circulation for lifetime. So the firstborn infants with Rh positive blood type are not affected because there is a long time of getting development of the IgG antibodies. So this response is called amnestic response, and these antibodies will affect the next Rh positive fetus. So, when the second pregnancy takes place, there will be IgG which enters into the fetal circulation via placenta, and they cause destruction of the fetal RBC, results in the fetal anemia, which is if hematocrit goes less than 30%, that is we consider it the anemia, which may cause a sinusoidal heart rate pattern. The heme is formed and converted to bilirubin, and there will be fetal hyperbilirubinemia. So, fetus excretes into urine, and the liquor becomes golden yellow, which is a condition known as icterus gravidarum. Bilirubin is neurotoxic, but in fetus, this bilirubin is effectively cleared by placenta and metabolized by the mother. So usually it is not affecting the fetus. Extramedullary erythropoiesis is stimulated, and hepatosplenomegaly with bone marrow hyperplasia will be there. Immature erythroblasts are produced, and hence this condition is called as erythroblastosis fetalis. Placentalomegaly develops, polyhydramnios will be there, and maternal PAH can also develop. So mother also become edematous, that is bloated. While in fetus, there will be hydrops, so there will be a halo around the head, which is known as a Buddha sign. And overall, there will be bloated appearance of the fetus also. So mother and fetus both are bloated, and that's why this is called as a mirror syndrome also. So various terms I wanted to explain how they come into play. That is icterus gravidarum or erythroblastosis fetalis or mirror syndrome or the Buddha sign. So this is the explanation behind them. Without any prophylaxis, the risk is 60%, 16% after 2 deliveries. 1.5 to 2% occur antepartum, and 7% within the 6 months of the delivery. Uh, Manifest early in the second pregnancy. With prophylaxis, the risk of development of Rh antibodies just 0.1%. The risk depends on three main factors. That is the volume of the transplacental hemorrhage, extent of the maternal immune response, a concurrent presence of ABO incompatibility. That is a protective risk also. The Rh incompatibility is only of medical concern for females who are pregnant or plan to get pregnant in future. Otherwise, if she is sensitized, she herself will not have any medical problems. How to manage the Rh negative pregnancy? So we have to ask certain points in history about the abortion, invasive procedures. Nowadays, a lot of fetal medicine specialists like us are there, and so invasive procedures are going on day in and out. Abdominal or pelvic trauma, APH in the form of either placenta previa or abruption, or intrauterine fetal demise, multiple gestation, manual removal of the placenta, ectopic or cesarean deliveries. All these can have fetal-maternal bleed, and it can lead to sensitization. So prevention of Rh sensitization in the Rh negative mother is the one goal, and the other goal is if she is already sensitized, early detection and treatment of the fetal anemia. So these are the two objectives or goals of the management. Sensitization is determined by the indirect Holmes test, otherwise called antibody screening. So whenever Rh negative mother comes in the first visit, you always ask for father's group. If father is also negative, there is no action to take. If father is positive, do indirect Holmes test. And now you can divide the patient into three categories. One is ICT negative at various stages. That is, first ICT we should start from 12 weeks, then 20 weeks, 24 weeks, and 28 weeks. So if all are ICT negatives, then that is category 1 patient. Uh, Another category is ICT positive at any time. And third is the category of the patient where previous baby was already affected with RH immunization. So category 1 patient, how will you manage? That is the administration of the NTD at 28 weeks and the NTD prophylaxis which lasts for 12 weeks. So there is no need of repeat dose during the pregnancy, and at the time of delivery you can decide how much dose is required depending on the calculation of the dose. So that can be repeated at the time of delivery. Some have recommended that 3 doses of NTD to be taken. That is at 24 weeks, at 30 to 34 weeks, and at the time of delivery. But nowadays, majority consensus is on the 2 doses. That is, one is antenatal and one is postnatal. Precautions during delivery by the obstetricians, that is, ensure the consultation with the neonatologist, because this baby may have anemia or hyperbilirubinemia. Don't give oxytocin at the delivery of the anterior shoulder, only give after the removal of the placenta. If manual removal of the placenta is required, do it very gently. If blood transfusion is indicated, use RH negative blood only to the mother. Early clamping of the umbilical cord is indicated, and leave a long length of the cord if in case you are suspecting that external transfusion may be needed. Postpartum management, you have to involve the neonatologist, collect the cord blood, and send the blood for blood grouping, direct home test, hemoglobin and bilirubin levels, and peripheral smear hematocrit. If fetus is negative, there is no further intervention needed. If fetus is positive and direct home test negative, then determine the dose of the antibody to be administered by 4-step laboratory procedure that we will discuss. And if you forget to give the NTD, that is a common question is asked in various conferences. If you are unable to give within 72 hours, you can give up to 28 days. You have to explain the risk of isoimmunization to the relatives, but you can give up to 28 days. If fetus is Rh positive and home stress is also positive, that suggests that the mother is sensitized, so there is no role of NTD. Check the fetus for anemia and icterus, and if needed, give transfusion. This is how the direct home stress is done. Here are the RBCs, that is the blood sample from a patient or the fetus, and these are the Holmes reagent where there is a anti-human antibodies are there, and if the fetus is already having antibody over there, and this anti-human antibody will bind with those, and they will form the clumps of RBC, and that's why this test is called as positive direct Holmes test. The 4-step laboratory procedure that I have told you to decide the dose of NTD is one is a Rosette RBC screen test. That is not mandatory, but if you have choice, you can do it in your clinic itself. So if it is negative, that means the fetal-maternal hemorrhage will be less than 15 ml, and so 300 microgram NTD will be sufficient. If Rosette test is positive, it indicates that the fetal-maternal hemorrhage is more than 15 ml, and you have to go for a Clehor-Bedke test or acid elution test. And in this test, they use citric acid phosphate buffer, and RBC of the mother will have acid elution, that is, they will elute from the solution, but fetal RBC are resistant to acid and they will remain in the solution. So we can count the fetal RBC. And after that, you can count with various formulas are available. Here are two I have written, and calculate the dose of NTD to be given within 72 hours. This is a Rosette test where you can see that this is a positive Rosette where these RBCs can be seen. Here is the acid elution. These are faint are the maternal RBC. They will fade away, but fetal RBC remains, and they can be calculated. So, if your estimation by Kleber-Patki test is up to 4 ml of the feto-maternal hemorrhage, you can reduce your dose to 100 microgram or 500 international unit. For every ml of the fetal blood above 4 ml, you have to add 125 international unit. So, whatever the milliliter of feto-maternal hemorrhage you have calculated, you can decide the exact dose of the NTD, and that much dose you can give on the deltoid or anterolateral thigh intravascularly. The RH NTD should be a polyclonal antibodies. In case of abortion or ectopic, which are less than 12 weeks, 50 microgram may be sufficient. But if more than 12 weeks, there are difference of opinion that 100 milligram or 300 milligram can be used. But for safer side, I would prefer 300. This is the indirect homestage which we do to the mother during the antenatal period. It is done at 12, 20, 24 and 28 weeks time, and here you can see that the serum from the recipient, that is the mother, is obtained. Suppose she is sensitized, so she will have the antibodies, and these are the donor, that is RH positive from anybody else. RBCs are taken and they are mixed. So this antibody will attach, and then the procedure is like a direct home test, and they will give the positive result if in the mother these antibodies are present. If these are not present, not be any agglutination. So indirect home tests give you the idea, and its titer also we should ask. Third category is a history of previous baby affected with RH isoimmunization. In both these categories, we have to monitor the pregnancy very closely. How we are monitoring, that is previous history, ICT titer, and ultrasound and Doppler. So ICT titer 1 in 2, 4 or 8 is okay, acceptable. But if it is 1 in 16 or greater, it is critical. In our Foxy Focus, 1 in 32 is given, but nowadays people have considered 1 in 16 as the critical titer, and our frequency of monitoring should be more if you reach the titer of 1 in 16. Best tool for monitoring of fetal anemia is middle cerebral artery, and today I have a big faculties of Surat, those who are doing fetal medicine, and they are masters of doing middle cerebral artery Doppler in case of suspected fetal anemia. So accurate and non-invasive screening tool for detecting moderate to severe fetal anemia is MCA Doppler. A sensitivity of 100% and 12% false positive rate also will be there. Use has resulted in up to 80%, or even I would say nowadays almost it is obsolete, amniocentesis and photosynthesis for diagnosis of fetal anemia, and those days of optical density are gone. Mary et al. They have reported that the use of middle cerebral artery peak systolic velocity is very useful in diagnosis of anemia way back in 1995. So we have now almost more than 25 years of the experience of using the MCA Doppler, and so many studies have reported that the MCA Doppler is far better than any other method for diagnosis of the fetal anemia. MCA Doppler is not useful before 18 weeks because the RES system is too immature to hemolyze enough cells to cause the significant anemia, and it is also not reliable predictor after 35 weeks. But we don't need it also. We can deliver the baby after 35 weeks. But in between 18 to 35 weeks, this is the best method, and everybody should use. Every gynecologist should know that the RH negative pregnancy should be managed by middle cerebral artery, and middle cerebral artery only. So that is the take-home message of today's whole seminar. Why MCA and not the other vessel? Because it is easy to identify, it is highly reproducible, and can be studied easily with an angle of 0 degrees. Therefore, information on the true velocity of the blood flow will be there. So those who are doing the Doppler study, they know the importance of the insolation angle of the pulse wave Doppler, and middle cerebral artery is situated in such a way that the pulse wave Doppler cursor will go parallel to the middle cerebral artery. So almost zero angle will be there, and hence the accuracy of measurement of the peak systolic velocity. That is, this one is a peak systolic velocity. This is the end diastolic velocity. So proper measurement will be there if the angle between the vessel and this beam will be near to zero. What are the criteria? How will you take during your ultrasound? So zoom your image. MCA should occupy more than 50% of the screen. Sample volume, that is the gate, should be 1 to 2 millimeter. Placed at 2 millimeter away from the origin. This is the origin of the MCA. This is the circle of Willis, and you can put here approximately 1 or 2 millimeter away from the origin. Angle as close to zero as possible, but up to 20 degrees variation is allowed, and three consecutive waveforms should be there in your screen, and avoid any unnecessary pressure on the fetal head. So this is the way how we should take and these are the various waveforms at different gestational age. These are in the first trimester, this is second trimester, and this is third trimester. So overall it is a high resistance flow. Diastolic flow is increasing with gestational age, but still compared to umbilical artery it remains less. So normal versus abnormal MCA. Here you can see this is a normal MCA and this is a very high peak systolic velocity. Other sonographic findings are sinusoidal heart rate pattern, cardiomegaly, dilated umbilical vein more than 5 mm, hepatosplenomegaly, bone marrow hyperplasia we cannot see on sonography, but hepatosplenomegaly can be seen. Placentomegaly, polyhydramnios that can be there, and hydros fetalis, that is a Buddha sign, also can be seen. These are the two charts where you can decide how severe the anemia is. Here it is showing the multiple of medians of MCA peak systolic velocity, and here it is the median, that is MOM is 1, it is 1.3, 1.5 and 1.55. So if it is between 1.1 to 1.3, it is considered okay. Frequency may be less, 2 weekly follow-up is sufficient. If it is between 1.3 to 1.5, it should be frequency should be high, and between 1.5 to 1.55, almost alternate day or daily monitoring may be needed. And when it crosses above 1.55, you should transfuse. Same way, you can plot your peak systolic velocity according to gestational age in this graph also, and these are the various areas. This D is repeat MCA every 2 to 3 weeks. Zone C is repeat every 10 days, and in zone B you can repeat 5 to 7 days, and in zone A you have to transfuse. So any of these you can use. You can take the screenshot of this because it is difficult to find for a routine gynecologist. Now management, that is unaffected or mildly affected. I have already told you that MOM less than 1.3, it is usually unaffected or mildly affected. Moderate is reaching up to 1.5, and severe is more than 1.55. If it is more than 34 weeks pregnancy, you can deliver and give transfusion postnatally. But if it is before 34 weeks, you have to transfuse. How much volume to be transfused? These two charts from Nicolaides help us to calculate the volume. So you have a donor hematocrit because you get the blood from the blood bank, and donor hematocrit you can ask the blood bank to maintain around 80. You are asking for the packed cell volumes. The fetal hematocrit you can decide the per of, that is you are puncturing the umbilical vein and getting the sample of the blood, and immediately in-house lab can give you the fetal hematocrit. Suppose for example we have taken it as a 10. So This is the graph. It will give you the volume of the uh, fetal blood volume at various gestational age. So suppose your fetus is 28 weeks, your blood volume will be total blood volume will be 100 ml, and with these two values, that is fetal hematocrit of 10 and donor hematocrit of 80, there will be a multiplying factor from this graph, and that factor falls at 0.8. So you have to multiply this 100 ml to 0.8 will give you the amount of volume to be transfused, and that is 80 ml. So for every gestational age, you can calculate this and you can give the exact volume with the help of these graphs. What we do, we don't know the blood group of the fetus, so we always ask for the O negative RBCs with high hematocrit, that is 80 or even more, and mother's fitness also should be checked, because it is a long procedure. We usually do under local anesthesia, but sometimes we can do it under anesthesia if the mother is apprehensive. The RBCs are irradiated RBCs. That is uh, it is helps in avoiding the reaction of other procedures, other blood group reactions also. So irradiation is very helpful. Here is a video I would like to share with you.
I will insert that needle into the umbilical cord. This is the umbilical cord.
So
you
this
can
is
see.
the umbilical
Can you put
cord.
the color here?
This is the placenta.
That. So I will reach to that part. Color usually overlaps the wall. So
we
during
don't
the
use color when
entering into the cord,
umbilical
we
cord.
do not use color. We go into
And this needle is a 22 gauge 7-inch spinal needle.
now
It is not 3.5 we usually use for MDF
I am
synthesis.
inserting the needle, and you can see the movement. I have to
Here you
maintain the
can see
direction of the
that,
needle
I am entering
while it is
through
entering
the
into the placenta, and it is going.
Here is entering.
Yes.
So now it is there into the umbilical cord, umbilical vein, and
It has not
I
given
can
me any sensation
feel
of
the
giving away, but
sensation.
I will test.
And here you
According
can
to
see
the
the blood is coming or not.
Yes, the cord blood is coming. You can see. उनकी बहुत धक्का
This
नहीं
is
मारना
the
है.
cord blood which we collect for various blood
And
tests.
this is the blood they are collecting for sample.
We take
We will test it for fetal blood group, fetal hematocrit, direct Coombs test, and karyotype.
Here is a
Now
device
he is attaching the device for
where there is a three-way
transfusion.
stopcock. Direct transfusion also can be done, but it takes a very long hours. Here he sucks the 20 cc blood from the bottle into the syringe and push it hard into the needle, so that the speed of transfusion will be high. And here you can see that the RBCs are going. Here there is a movement of
To
the blood.
transfuse fast, he has used 20 cc syringe. You can see the position of the needle and
Follow-up
blood.
after intrauterine transfusion, again it is done with the help of middle cerebral artery peak systolic velocity. You can see that pre-transfusion the peak systolic velocities are high. Immediately after transfusion, it will fall. Again, after few days, it goes on rising, because there is a process of hemolysis goes on. If necessary, we can give another transfusion. That way, this graph goes on hips and bumps. So, intrauterine transfusion is recommended only for severe anemia, and typically carried out between 18 to 35. After 35, usually we deliver, don't give intrauterine transfusion. Transfusion, if you are expert, you can give intravascular, which I have shown you in the video, but intraperitoneal transfusion also can be given. O negative irradiated packed cells with hematocrit of more than 80% is used, and the amount to be transfusion, I have already showed you the graphs, but this is a simple formula that GA minus 20 multiplied by 10, where GA more than 20 weeks is used. Another simple one is for detection of the anemia severity is MCA peak systolic velocity double the gestational age. For example, your gestation is 24 weeks and MCA peak systolic velocity is more than 48. You might have crossed 1.5 mom. So that is the time you should refer to the fetal medicine specialist. I would say you should refer little earlier than that. Postpartum management of the neonate. We have said that what is the management of the mother, but neonate, if baby is alive, should be admitted into the ICU, and if urgent transfusion is indicated, in moderate to severe anemic fetuses, and phototherapy for mild affection can be done. Special feto-maternal risk states are abortion up to 5% chances of sensitization and 50 microgram is recommended. Some of the studies I have seen that spontaneous abortion usually doesn't have feto-maternal bleed, so you can skip. But personally, I would say we should give in all spontaneous abortions also. Invasive fetal procedures up to 11% sensitization. So dose of 300 microgram is recommended even if you are doing amniocentesis or coronary biopsy. Antepartum hemorrhage 300 microgram state at the time of hemorrhage, and it should be repeated 12 weeks later because 12 weeks is the time of action of the NTD. So if pregnancy lasts longer than 12 weeks, then you should repeat the dose. External cephalic version nowadays it is a lost art, but if somebody is doing, there are 6% chances of RH sensitization, and again 300 micrograms should be given at the time of version. What are the new things? Is non-invasive fetal genotyping, that is from fetal cell-free DNA in maternal circulation. We all are now doing NIPT from the maternal circulation, getting the fetal DNA. Same way we can do the fetal RH grouping also from fetal circulation. That is underway, not available in India right now. Point of care test, that is rapid test for determining the RH status. Fast we can get the RH status. A lower 50 microgram dose preparation is now available in India also for first trimester abortion. And the concept of partial D or weak D antigens are also upcoming, which may be tested positive and can produce antibodies. What are the problems in our setting in India? There is a high cost of the immunoglobulin, lack of resources to adequately investigate and monitor the fetus in utero. Number of fetal medicine specialists are still low. Low turnout for antenatal clinics, missed cases, and poor documentation of prior sensitizing events. That is, a patient may not give you the history or documentation may not be there, and loss of case logs. So these are the problems we face day in and out. So recommendations are advocacy of partnership with government and NGO to subsidize the cost of the NTD. Special insurance cover for RH negative women to ensure the ease of procurement. Involvement of clergy as part of premarital counselors, and the creation of the special groups of RH negative people so that they can have RH negative spouses also. So sensitization can be reduced. So in conclusion, RH elimination is a real problem, and the real efforts are needed to be made to mitigate its impact. Its incidence has decreased dramatically, but the consequences of hemolytic disease of the newborn remain. Great advancements have been made in the detection and management of this condition, and many of our RH negative women can now have a happy obstetric career. This is the algorithm. You can have a screenshot. This is from the Foxy Focus. It is, I think, 2009. Here you can see that the husband's blood group and the genotyping is also advised. But this you can skip in your routine management because that adds to the extra cost. If homozygous, the fetus always will be RH positive, but if heterozygous, it can be negative. So anyway, you have to monitor this way, so it doesn't make you thing. Another change I would say is here, that is 1 in 16 is a new critical titer for the indirect Holmes test. So thank you. I would stop here. This is the middle cerebral artery. Anuja, anything you have to say, or should I proceed further?
No, sir.
Okay, so I would proceed with the next session, and that is a most awaited thing because it is a practical aspect. So a few cases and case discussions will be there, and the panel will be moderated by none other than my secretary, that is Darshan Badekar. Surat, this time we are proud that both fetal medicine specialists are on the post of president and secretary. Uh, Darshan is a gynec surgeon. He is a director of Vadekar Hospital, Ring Road, Greenleaf Hospital, Vesu. He is my Guru Bhai, that is, he has also done his fetal medicine fellowship from Chennai under Professor S. Suresh. But he has also gone abroad, that is US and UK, for further fetal medicine experience at various universities. He has been invited as faculty across the country for high risk pregnancy and fetal medicine and has trained more than 500 gynecologists for the same. He was one of the youngest faculty at Ian World Congress on Human Reproduction at Dubai. Famous online show, that is TEDx, has invited Darshan for his innovative work in the field of high risk pregnancy and fetal. So I would invite Darshan to proceed for the further discussion with the panelists. Darshan, you can go ahead.
Yes, sir. Um,
Anuja, please stop sharing.
should I try?
Okay, yeah. Go ahead, Darshan.
Yes, sir. I'll try and share this. I hope it is visible, sir. I think. Thank you very much, sir.
Darshan, do you have the biodatas of the panelists?
Yes, sir. Yes, sir. I have shared that screen. I suppose.
Doctor, enable edit first. You have to stop sharing and enable
Editing
Sure, sure. One second.
in the yellow line.
Yes, sir. Yeah. Can you see?
Full screen.
Yes. Yes, sir.
Yes, we can.
Yes, sir. So, thank you very much, sir. I think it is always a pleasure to discuss such interesting topic with Jayesh bhai and with Hitanshu and so many others around. I'm sure instead of the panel, I would put it across as more of a discussion wherein we can understand the intricacies, because sir has very well elaborated the actual procedure of how we can go through in a RH non-immunized or an iso-immunized pregnancy. So from that perspective, I would like to invite our first panelist, Dr. Hitanshu Bhatt. Dr. Hitanshu Bhatt has done DNB from Fernandez Hospital, Hyderabad, and he has also done fellowship in an advanced OBGY ultrasound with Sir Professor Suresh. He has his own clinic, fetology clinic at Surat, and is also a super specialty consultant at Smimmer Medical College. He has been awarded as the best poster for ISUOG in 2015, and also awarded poster prize in ISUOG 2014 for PUE and interventional outcomes. Also, I know he is not just academically oriented, clinically as well. It is always good to discuss with him on various topics. He has also presented a case on pseudo incontinence of urine with labial agglutination, and has also been a part of the obstetric emergencies line life-saving skills. The second panelist with us is Dr. Deepa Vagarsia. She has done fetal medicine from Bangalore, uh, and she has done from Krishna Institute of Medical College, Medical Science, Karad, and has also completed fellowship in 2019 under Dr. Pratima Radhakrishnan. She is certified FMF UK for anti-scan anomaly as well as Dopplers and has presented posters and paper. Presently, she is working as fetal medicine consultant at Healthum Fetal Medicine and Diagnostic Center, Hirabag, Surat, since October 2019. The next panelist is Dr. Paras, who has done his DGO from Nasik and has been since 6 years independently and extensively working as a consultant gynecologist. Since 4 years, he has his private hospital in Botat and is been working in the civil hospital for full time for 1 year. Now, he has special interest in doing detailed anomaly sonography as well as routinely performing these cases and special interest in terms of non-vaginal hysterectomy. He is also a certified sonographer from FMF. Next is our own Dr. Bhavesh Patel, who has his center at Sonoscan Fetal Medicine Center, Surat. He has done his MS and he is uh, done his education from DJ Medical College, Ahmedabad. He's been working at where he had worked at Mediscan in 2015 for 1 year. So welcome all. I would now share the PPT. So we all know RH isoimmunization and RH negative pregnancy, and as Sir has already explained that the mother is negative and the fetus is positive. While I was going through some of the articles, what was interesting is to understand the pathogenesis, wherein the initial RH antigen has been identified in the red cells by around 38 days after conception, and the initial response has always been found to be slow, and that is the reason why we initially have the primary pregnancies, in spite of the silent exchange, do have negative titers during the pregnancy. And as then the second exposure, when it comes in the second pregnancy, uh, the basically we have a rapid immunological response, and that is the reason why in the subsequent pregnancies we are needed to do intrauterine transfusions, which then affects that pregnancy and helps the pregnancy to have a better outcome. Um, I'll start with some of the basic questions as to what, whenever we say RH negative pregnancy, what do we mean really by it? Dr. Deepa, are you there? Can
Yes,
you
yes,
repeat the
I'm
question?
there. So, as we all know, we have two systems of blood grouping. One is the ABO blood grouping and one is the RH. Whether it's positive or negative, it depends on the presence of antigen D on the RBCs. So, when antigen D is not present on the RBC, that individual's blood group is labeled as RH negative pregnancy. So, when the mother is RH negative, it means that the mother's blood cell doesn't have antigen D on the RBCs.
Right. And so when we call it isoimmunized, those.
So Rh isoimmunized means the mother is Rh negative and the fetus is Rh positive, means the fetal blood cells has the antigen D on their RBCs. So when these bloods and these fetal RBCs enter into the maternal circulation, there will be sensitization of the immune because of the immune response of the maternal system. There will be production of antibodies in And this condition specifically is called as Rh isoimmunized pregnancy, when the fetal blood enters into maternal blood and production of antibody in the maternal blood.
Right. And so, if I take the next question to Dr. Paras,
Yes.
in terms of ICT and DCT, can you elaborate a bit?
So ICT is basically indirect Coombs test. So in indirect Coombs test, we perform this test on the maternal blood to know whether the mother has been sensitized previously with the Rh antigen from the previous fetus who was Rh positive. So basically it gives us information in this current pregnancy to manage further how to manage this pregnancy regarding if it is ICT positive pregnancy. If it is the test is positive, then we have to manage this pregnancy as Rh negative pregnancy which has been sensitized, and we have to do serial MCF Dopplers as we have already learned today from Dr. Jayesh sir's lecture. And DCT is direct Coombs test. Direct Coombs test is utilized to know it is done on the fetal blood to know that whether maternal antibody is there in fetal. Are the fetal red blood cells are sensitized with maternal antibody or not?
Right. So basically, it's a direct antiglobulin and an indirect antiglobulin test. That's where we differentiate, and more commonly, it is used in the prenatal side, ICT. And any importance of Rh titer in Rh isoimmunized pregnancy? Bhavesh bhai.
I'm audible?
Yes, very much.
Yes. Initially, to diagnose pregnancy, whether it is sensitized or not, it is being done to rule out antibody. But once it has came out to be a positive, then I don't think for me it is needed to be repeated. MCA PSV is a better marker to monitor the fetus.
Right. And I think earlier it was used when we were not using the doctors.
Yeah.
So, Hitanshu, any importance of serial or critical titers? Do you use critical titer values, or do you take it into consideration? Hello?
Yes. Can you please repeat the question?
Yeah, I was just asking whether you utilize the critical Rh titer value, or do not consider it?
Yeah, generally 1:16 is the titer value which
Correct.
we use as a threshold. But it may vary based upon lab to lab, and the titer, the techniques that they are using. So better to communicate with the lab and ask them what critical titers they are using. But overall, unanimously, 1:16 is the titer which we generally follow. Once it is positive, there is no to repeat the titers, because it may not be helpful assessing whether the baby is progressing to anemia or not.
Right, but has there been any experience, because since all of us are doing intrauterine transfusions, do you have any experience wherein if the titer is 256 or if the titer is 32, then only those patients will go into for transfusion or need transfusion?
Now in the era of MCA PSV the based management, the titer value does not pose any significance. And they do not directly correlate with the extent of anemia or progression to anemia on hydrops. So,
exactly.
So there are cases in which that will be helpful.
So if I put it on the lighter side, if I put it on the lighter side, like in COVID, we have been seeing so many patients with a 5% positive in CT scan going to ventilators, and 40% of CT scan values are still needing only 2 to 5 liters of oxygen. Similarly, I think Rh titers are very important from diagnostic perspective, but beyond the diagnostic value, they have no further value in terms of management and treatment. I think we all agree on that.
Yes, definitely.
So, I think Dr. Deepa, when we start, we are back with to you. A 30-year-old female. What we are going to discuss three parts. One is the RH non-immunized, iso-immunized, and in terms of intrauterine transfusion. So, 30-year-old female, primary gravida with 3 months amenorrhea, came to you for a routine ultrasound and an antenatal profile, which was found to have her blood group as AB negative.
Okay.
How do you approach this pregnancy?
Okay. So by doing the ultrasound, I'll check for the gestational age first, and
Right.
she is AB negative now. So I'll ask her, and primary gravida. So I'll make sure that she's actually primary gravida, because many a time when they have prior MTPs or prior
Very true.
spontaneous miscarriage, they don't consider it as a pregnancy, and they consider this pregnancy as a pregnancy. So I'll cross check whether and make sure that she is actually primary gravida. Ask for the previous history of blood transfusion, and I'll check for the husband's blood group as soon as I get the maternal blood group result. And next I'll ask for her to get ICT done on the first visit itself.
Right. And right. So you, I just missed the word in between. You checked the husband's blood group and then you went for the RH titer. That's what you
Yes,
said.
yes.
Right. So, Dr. Bhavesh, how will you?
Darshan, you have not appreciated Deepa that she is the only female member of today's faculty list.
Sir,
We have others also, sir.
sir, the respect, that is the respect that I'm giving her by asking the first question.
Thank you so much,
Okay,
sir.
ladies first.
Sir,
Okay, go ahead.
yes, sir. How frequently will you monitor RH titer, Dr. Bhavesh?
It is slightly controversial. Better to monitor with RS titer, better to monitor with MCA PSV. I think so.
Even first pregnancy.
So I would prefer MCA PSV for monitoring.
Right. Right in the first pregnancy, correct? Non-immunized.
Yeah. First pregnancy.
Okay. And that is okay. And then in case of the first trimester, if that means you mean to say basically if the RH titer is positive, then you will start looking for it. But if the RH titer comes out to be negative, then you will
Then
probably monitor it.
then we can repeat in later pregnancy.
Yes. That way we can do it. And so, Hitanshu, and I think we can ask you this question. In case of the first trimester, complication, how to be managed, or Dr. Paras, if you want to come in.
Yes.
Yes, Dr. Paras. So, in case of the first trimester complication, maybe many times we see, what would you like to do next?
So in first trimester pregnancy complications like in miscarriage, threatened abortion or ectopic pregnancy, after miscarriage we have to give generally as per the dose calculation the recommended dose is 50 microgram, but in India 50 microgram commercial preparation is not available, and hence we will give 150 microgram NTD to that mother.
Yes. And I think silently we don't know actually how much. So ideally we are supposed to do even FMA, I mean clear bed ke later on, but I think it's not practical. So we usually give 150 or 300, and so this was one of the guidelines which I would like everyone of us to look into, wherein they have beautifully described on this the international units, and we all look into 300 micrograms as the measurement, but international units it is 50 microgram, around 1500 international units is equivalent to 300 micrograms. So Hitanshu, if I put it across that patient has a increased first trimester screening, and you need to do a CVS or amnio, how would you like to go ahead with?
Because of availability of 150 microgram at present in India, I would like to give 150 microgram after the procedure, because 50 is not available. Otherwise, it would have been sufficient. And
And
yes,
yes, go ahead. Go ahead.
because these procedures do carry the risks of fetal-maternal hemorrhage and communication between the fetal and maternal system, so better to give them prophylactically, and then give them the 150 microgram is sufficient.
Right. And any change from CVS or MNO, would you change, or it
Uh,
would be the same dose?
yeah, same dose, maybe same dose. Yeah, because in the first trimester you mostly do CVS, in second trimester you do amnio, 16 weeks onwards. So I
Right.
think the same dose would be enough.
Enough. True. And so, how do you assess the fetal-maternal hemorrhage?
Yeah, generally 300 microgram what we give, that would be sufficient enough to cover up almost around 30 ml of fetal blood, or 15
Yes.
ml of RBCs. So in general, most of the fetal-maternal hemorrhage what we see in routine practice would be covered with this much dose. But if repeated episodes keep on coming, and we don't know whether to give them or feed them another doses, then better to have the utilities of this kind of test, like Leher-Butke test and flow cytometry and rosetting technique. So that can tell us whether whatever we have given, whether any another amount has to be given to the patient or not, to neutralize the antibodies.
Right. But I mean, Jay sir, you are also there. I mean, how much practically we use these? Do you regularly use it?
No,
Not really,
it is
right?
not available in Surat.
Exactly. So I think it's more on the theoretical side, but I think yes, practically we just assess it,
Actually, we should ask the lab people that they should start this
start
at
doing it.
least Leher-Butke,
Yes,
so
sir.
that we can have an actual amount of fetal-maternal hemorrhage.
True, sir. So next question: in case of abruptio placenta, how would you like to proceed? Anybody, Dr. Paras wants to take it, or
Yes, in case of abruptio placenta, we have to give if the abruption has occurred around 20 to 30, 20 to 24 weeks, around 24 weeks, then we have to give 150 microgram. And if it is mild abruptio placenta and the pregnancy is continuing, then every 6 weeks or we have to give the NTD, because the half-life of the NTD is around 6 weeks. Then if smaller amount of fetal-maternal hemorrhage is going on, then we have to give 150 microgram every 6 weeks. And if the abruptio placenta occurs after 30 weeks, then we can give 300 microgram of dosage. And if still pregnancy is continuing beyond 36 weeks, then we have to again repeat the dose of 300 microgram.
right? And
Here I
anything?
would like to add that if bleeding has stopped,
Right,
you
sir.
can delay the dose up to 12 weeks.
Yes.
Right, sir.
If bleeding is continued 6 weeks, is okay. But if there is no bleeding,
Yeah,
then
if there is
you
no
can delay
bleeding, I
the
think we
second.
don't need to add more onto it. Right, sir. In terms of once the baby is delivered, anything? What measures you would like to take? Anybody would like to take that question?
Early cord clamp at the time of
Yes.
delivery. And one thing we need to, before to deliver them, because we usually repeat ICT, first test booking and repeat ICT at 28 weeks. So the NTD has got shelf life of 12 weeks. So we need to deliver them by 40 weeks, not to go let them becoming post term. So then, so delivering them by 40 weeks would be the ideal plan. And then active management of third stage of labor, the early cord clamping, and not to mingle with the placenta much. Even if MRP is needed, then we need to substitute another doses. Then we need to take the cord blood. We need to keep as Sir said, we need to keep the cord end a little bit longer than usual, and we need to do few investigations like from fetal cord end, like hemoglobin, hematocrit, fetal blood grouping with RH grouping, and the DCT, direct Coombs test, to assess whether
Yes.
The thing has occurred or not. Then we need to theoretically we need to quantify fetal-maternal hemorrhage, but as we just discussed, it is not practically possible. Then if once it is confirmed that DCT is positive, we need within 72 hours we need to administer 300 micrograms of NTD to the mother, and we need to tell them that in all subsequent pregnancies you need to come up with the ICT. You need to do the same things like in the booking new ICT, and then you need to monitor your pregnancy. So this much sensitization before discharging the patient is necessary.
So I think, but additional doses, I think nobody of us usually uses it for the same, but except where in a very clear case of abruptio or something is there, only those cases. But I think in routine practice, 300 is the max which most of us are giving. Anybody has any difference of opinion on that?
Because guidelines say around 500 international units.
But today we should pass the message that if majority of the gynecologists they ask for cleverpatki to various laboratories,
I think
then we can give the accurate dose to the mother.
Right. Very true.
So laboratory people should come forward, and we should insist them that they should start doing it.
Absolutely, sir. And in fact, that would also save a lot of more iso-immunized pregnancies, sir.
Right.
Right, sir. Yes. Dr. Deepa, you there any role of MCA PSV as we discussed? I think Dr. Bhavesh already mentioned.
Yes.
Yes, go ahead.
Yeah, it's the most important tool in case of RH negative in this era after the mother is ICT positive.
Correct.
Now we should be monitoring MCA PSV later on, depending upon the titer. Now, if the MCA PSV is normal, Dr. Jayesh had showed that chart. If the MCA PSV is normal, then we can follow up the pregnancy accordingly. They had showed the A, B, C, and D group. Whether it falls in the D group, then the 2-weekly monitoring, C group, then 7 to 10 days, and then accordingly we need to monitor the pregnancy based on MCA PSV, because it is the most important tool. When there is anemia, blood is thinned out. So increase blood circulation to the brain, and that is the first sign we'll be seeing in the fetus as a sign of fetal anemia, which is we can detect by the MCA PSV Doppler. And I think ideally it is a good method to at least note the MCA PSV from anomaly scan around 20-22 weeks onwards, so that we'll be having the baseline MCA PSV value and give the patient a big chart, so that whenever patient goes for the further scanning, they can just plot the MCA PSV value on those chart and see the pattern of the chart, pattern of the MCA PSV value. If it is in the rising manner, it suggests that we need to monitor this pregnancy more close. If it is like maintaining the graph, then no need to worry much about that pregnancy.
Right. So basically, we all agree. I don't think I should ask this question to amongst the panel that any role of serial titers. We all are very clear that there is no role of serial titers in that sense. And so, as you were discussing, and I think Sir has also mentioned in his lecture. But I have one question, which is, have you found that by applying a little bit of more pressure, the MCA PSV changes?
Yes.
Yes.
That usually happens in third trimester. We do growth scans with Doppler, and even in RH positive mothers, we find a little bit higher PSV. Then after some time, if the fixed head has gone a little bit up, and then we see again it comes normal. So repeated measurements and
in practical
techniques would be helpful.
Right. And I think this goes on with a lot of referrals also, which are sent as high MCA PSV turning out to be normal. And the second is probably the angle of insonation, which also becomes extremely important in those terms. Dr. Paras, you want to comment something on that?
Yes, the angle of insolation is very much important in MCA Doppler. The insolation angle should be in such a way that our the ultrasound wave and the direction of the middle cerebral artery is both are in parallel direction, and we have to put the pulse wave Doppler uh, in the proximal third portion of the middle cerebral arteries at the circle of Willis, and then we have to ensure that the fetus is not breathing, there are no hiccup or there are no excessive fetal movements, and we should be doing this fetal Doppler like we perform the ductus venosus Doppler in first trimester as in fetal quiescence.
Very true. Uh, and I think that is very true that quiescence is a really important aspect which we should consider. And so, Dr. Bhavesh, when do you consider to do IUT?
Mm, uh, Whenever first if I see MCA peak systolic value corresponding to 1.5 mom, I will repeat it again after 4 to 5 days. If it's still coming to 1.5 mom, more than 1.5 mom, then I will think of doing an IUT.
True. And more importantly, I think we all agree that whenever we find anything a little bit abnormal, we at least take 2 to 3 values in the same sitting as well, just to be very sure of what PSV we are mentioning. And this actually is more for routine in routine practice also. That is one of the reasons why we probably ask the patient to wait for some time, come back, and probably reassess the MCA PSV before we give a final value to it. Anybody, Hitanshu, you would like to describe on the protocol?
Yeah. Once we have determined that this is a potential candidate for important transfusion, first thing is we need to do a thorough counseling with the patient, means the couple, and we need to tell them the pros and cons of the techniques, the risk involved in the procedure, because it's being an invasive. Definitely, it would have its disadvantages also, but the advantage part is a little bit higher, and then it's a life-saving technique, so we need to do it. The first thing is the acquiring the blood product. That is very important. Better we have Rh negative pack cells, saline washed, leukodepleted, and gamma irradiated. Gamma irradiation is important because it will prevent the graft versus host reaction. And sometimes many times it has happened that the only one laboratory in South Gujarat is providing gamma irradiation, and the technician goes back at home around 6:30. If patient lands up late in the day, then we have to postpone it to the next day. So acquiring blood product is very important part, and the quality of this should be as I just mentioned. Then once we have acquired the blood with the constant ultrasound guidance, we need to identify which route we are going to, whether it is transhepatic in the portal vein, or through the umbilical insertion, placental insertion of the umbilical cord, or in the free loop. Free loop is less preferred because of the mobility of the cord, the needle may come out. And the first technique, first thing we need to do is to ensure the fetal paralysis, so that our procedure would be smooth enough. Fetal paralysis can be done with 0.1 milligram of pancuronium or atracurium or vancuronium intramuscularly with that long spinal into either deltoid or thigh aspect of the baby. And then after choosing which route we are going to, under constant ultrasound guidance, we need to introduce the needle. Jayesh sir has very beautifully shown the technique, so I'm not going to describe the whole technique. And the amount of blood volume, what we are going to do, how much we are going to give, that also that technique or that charts also have been nicely shown by sir. So total fetal blood volume we need to calculate. Then we need to know the target hemoglobin and the baby's hematocrit, as well as the donor hematocrit, and based upon that there are calculations to be made, and that's how we perform this procedure. Whatever the blood sample which has been taken from the baby, also that also to be run for apart from hemoglobin, hematocrit, and blood grouping, direct Coombs test, and preferably karyotyping, so that we are not missing out any other problems which may happen in postnatally. So better to go ahead with this.
Right. And Dr. Deepa, if I may ask you,
Yes.
you also prefer pancuronium or vacuronium?
Etracurium we used to give depending upon the fetal weight, 0.1 milligram per kg per kilogram of fetal weight.
I think nowadays we are also using vacuronium in
And
in
in
terms
many
of
cases where the placenta is anterior,
No need
yes,
to give
no need to do it.
because we can
Yes,
give the
sir.
intravascular blood transfusion itself at placental cord insertion site.
True,
so when
true.
I select the placental attachment with anterior placenta, I usually avoid giving the pancreas
We
fluid.
don't.
Right, sir. Right, sir. Sir, and that's the same way. If we even if we give, for that matter, it has to be given to the same needle in the first prick. So it is not like another prick onto the fetus. It is through the same needle that you're just giving 0.1 ml, 0.1 milligram, in fact. And once the calculation has been done and transfusion has been done, Dr. Bhavesh, what would you like to? When would you like to call back the patient? Around how many days later? Or
Uh, Initially, I would like to follow patient every weekly.
correct?
So post transfusion, weekly follow up
I
I will keep.
absolutely. And in fact, I think 1 milligram. I think Hitanshu would like to add
Yeah,
the dosage.
there would be a fetal hemoglobin loss. So
Yes,
so the thing
you can.
happens typically with the first transfusion is the fetal reticuloendothelial system is so hungry that it will eat up the whole chunk of blood given. So the second transfusion would be a little bit earlier. Then
Earlier than the second one.
once the adult RBCs have replaced the circulation, then the second transfusion
It
can
will
be
go.
delayed later on. And 1 point instead of 1.5 MOM, what we are taking for first transfusion as a cutoff, there are evidences to show that now we need to take 1.7 MOM for subsequent transfusions
Subsequent
because of
transfusion.
the combination of both the RBCs, fetal as well as adult. So that thing we need
Right.
to.
Right. Dr. Paras, there's one other aspect which I think most of us still do portal vein or the commonly placental. But any experience on terms of peritoneal transfusion?
No, personally, I don't have experience of any intrauterine transfusion, but
Uh,
you said that intraperitoneal transfusions in your beginning, while you are learning, when you are learning intrauterine transfusions, then it is easier to perform. The intraperitoneal route is easier to perform,
Perform. True,
and
true.
in case of earlier gestation. In case of earlier
Yes.
gestation, around 20 weeks, 18 to 20 weeks, intraperitoneal transfusion is possible, and intravenous access is very difficult. So, in early
True.
gestational age, we perform intraperitoneal transfusion.
Very true. Very true. In fact, non-immune hydrops is also one of the indications wherein there is a slow absorption from the peritoneum, and hence it gives us a longer duration between the two transfusions. Many times in those cases, uh, that's what we use. So I think we've almost.
I would share my experience. In one
Yes,
of the
sir.
patient when I was doing intrauterine transfusion, mother moved during the transfusion, and
Okay.
there was a counter puncture, and then I could not re-enter the vein.
Right.
So, and fetus was having a spine anterior position. In that case, I did the intraperitoneal transfusion, and
Right, sir.
it was nice. So, when
Yes,
there is a technical difficulty, if you are facing, then you can go with intraperitoneal.
true, sir. And you kept the dose the same,
No, little bit reduced.
relatively reduced, right, sir? True,
Because
sir.
upward movement of diaphragm would cause respiratory embarrassment if
Yeah,
we
respiratory.
Very true, sir. Very true. So I think we've almost covered. Any other points you would want us to cover, or anybody wants to discuss, Dr. Deepa, Dr. Paris,
Uh,
Dr.
I
Bhavesh, Dr. Itanshu?
for MCA PSC doctor, we in practical day-to-day practice, we observe that many a times in strict BPD plane, that when midline fox is horizontal to the ultrasound beam, then MCA middle cerebral artery, the proximal portion through which we want to interrogate is not in the correct angle. So we have to a little bit uh, make the fetal head oblique by maneuvering the probe, and then we can get the correct insonation angle. So we have to
It's not completely horizontal. That's what you're trying to say.
Yeah.
True. True.
One question I would like to ask is why entity should be given on deltoid and not on the gluteal?
yes, we have the most important point. We have to give it in deltoid, not in gluteal, because in gluteal muscles, when we use the intragluteal route, then we are very distant from the muscles, and we might end up in giving the whole dosage into the subcutaneous tissue, and the absorption of the NTD might be delayed, and
Delayed.
we would get the desired NTD effect. And it might be false belief that in previous pregnancy it was given within 72 hours, but we have to ask the patient history also, that the injection was given in the buttock or in your arm.
Yeah. Very good. In fact, I think some of the questions has been shared from the audiences, and I'll just put it across. Um, is it mandatory to perform Claire-Berke test before giving NTD? By Dr. Sonali Agrawal from Vadodara.
Ideally, it should be.
Ideally, yes, but I think practically, as per availability, I think we have to take a call on that. But
Actually,
second
our
question
association
is
should impose the laboratory people to make the test available, and we should sensitize the gynecologists also to use that test when the laboratory people make it available. So it is better to use it.
right, sir. That's right. Yes, sir. If they, if, it is the same way how laparoscopy and fetal medicine came into picture, I'm sorry. Because of demand. Is there any effect on the child if both the parents are having O positive blood group? This has been asked by Mrs. Bhavna Chauhan. Dr. Deepa, you want to comment on it?
If both the
Is
parents
there
are
any effect on the child if both parents are O positive blood group?
usually not, no.
Yes. I think I think she probably meant to ask whether it is O negative blood group. Both are negative. Maybe that's the question. I think if the husband is negative and the mother is also negative, then I think it will be RH non-immunized pregnancy only.
Yes.
If ICT if ICT is positive in the in previous LSCS with an ICT quantity of 1:1, what would you do, Dr. Itanshu?
At what time they have done the test and in which trimester, and whether in previous supplementation of NTD was there in previous pregnancy, that I would look for. And 1:1, we need to check with the lab how much titers they are following to call it as a positive. How much critical titers they believe. So either I would like to repeat the test, or after knowing all these details, then I would take a call.
True. In fact, and secondly,
One
maybe
means
repeat
there is
after
no
based on
neutralizing. They don't have to dilute anything.
really that, absolutely. ICT version previous. The other question is ICT again 1:1 in previous must be LSCS patient at 32 weeks. What should be the next management? Does they require amnio? I think there's some
MCA PSV based monitoring, considering it
yeah
positive
MCA,
rather
yes.
than considering as negative and going for other testing.
We can straight away go with MCA PSV.
Yeah.
Ultimately, we have to treat the anemia.
Exactly.
Right, sir. The other question is, does all primigravidas need to be tested for ICT routinely?
Yes.
Yes.
Yes,
At booking and at consultations.
because as Dr. Deepa mentioned, in our in today's practice, we there are many nowadays. The MTP kit is readily available as an over-the-counter medicine, and a patient or that lady might hinder the history of previously taken MTP pills through chemist only. So we have to keep that thing in mind also.
True.
Even in primary silent phytometal and hemorrhage we can't rule out.
Yes.
Yes.
For all practical purposes, if patient is affording, then we should advise ICT in each primary gravida.
Doing ICT is non-invasive and non-harmful.
Yes. Should we give NTD in threatened abortion
Yes,
without
definitely.
pain and no recurrent bleeding? Medical treatment of ectopic or medical treatment of abortion? I think we covered this question.
Should
In
be
the sense, definitely we have to give. How to proceed in indirect Coombs test positive at 20 weeks for Dr. Uma Maheshwari. Can anyone, Dr. Bhavesh, you want to take?
Yeah. If ICT is positive, we have to monitor by MCV, MCA PSV. Yeah.
Very good. Very good. And based on once it reaches 1.5 and beyond, we will then think of
And we have
intervention. What is the role of ICT during abortion? When should we do the test? Dr. Pratik from Mumbai is asking this question.
Any sensitization and presence of antibodies can be detected. That is IgG antibodies 6 weeks to 6 months if you take. Yeah, you can test at 6 weeks. If negative, then we have to repeat the test also.
Right. So, do you people have any list of such clinically significant antigen donor list which can help during transfusion if required in these patients? I'll repeat the question. Do you people have any list of such clinically significant antigen donor list which can help during the transfusion if required for these patients?
I think they may be O negative donors with high hematocrit.
Yes, I think most hospitals, most blood banks,
They have
they have the list with them.
and they call them and they
Because I think one of the important aspect in IUT is fresh blood, less than 5 days. So most of the times, if it is not available and not fresh, I think they anyways call for. And I think also antigens in that terms, she might be asking any other antigens apart from ATD that we look for. I think NTC is also being looked upon, not in India, but I think in other countries. If a case of antepartum hemorrhage bleeds off, and if a case of antepartum hemorrhage bleeds off and on throughout the pregnancy, how many times she requires NTD? Dr. Sangeeta Kumar. So I think Dr. Jayesh Bhai already mentioned that answer in the sense that if there is no bleeding, you don't need to repeat it. And again, the Claire Betke would be a very, very important role in this case, wherein we will get to know if it is showing more than 4 ml of bleeding which is taking place, you may need to repeat the NTD. Otherwise, single entity, I mean, usually 150 is needed. We can give 300, and it should cover the antepartum hemorrhage. Do we?
12 weeks.
Sorry?
Up to 12 weeks. If a pregnancy lasts longer than 12 weeks, then it should be repeated.
It should be repeated. Okay. Do we give NTD after delivery, even if the patient is ICT positive? Does it give slightest protection also, even if ICT is positive? What is the prophylactic dose antenatally? Okay, first question is up to here. So, Dr. Paras, would you give
No.
the NTD?
If ICT is positive, there is no role of
No role.
to the mother.
Absolutely. The body has already produced that antibody, and so no need. Prophylactic dose 300. I think that's what we discussed. Is ICT test recommended before giving NTD when a patient has retroplacental bleed? Dr. Rashid.
We can give empirical dose.
Is ICT test recommended before giving NTD when the patient has? Yeah, I think ICT test, but I think empirical dose would be a better option. Calculation of the dose of
You are doing a direct home test at the time of delivery.
Yeah.
So, antepartum bleed,
Okay.
retroplacental bleed, antepartum bleed. Calculation of
Yeah,
the dose.
then it is better. Empirical entity is better.
Yes. Calculation of the dose of NTD to Rh negative mothers after delivery. Depending on the amount of fetal-maternal hemorrhage, Dr. Niranjan Nayak. Yes, I think again, I think we all are coming back to the same aspect which we were discussing, that Kloher-Betke test has to be.
Kloher-Betke is required.
Is high. It's high time that we should now implement and try and bring it down, so that, because I think most of us would agree that even when we call the blood banks for an intrauterine transfusion, it takes a while to make them understand why we need a double pack cell instead of the single one. And when the consultant listens to it, and only then they approve to give us the same. So I think with the increasing number of high-risk pregnancies and all of us being around to do intrauterine transfusions, I think we should bring in Kloher-Betke, which will be helpful to the society at large. I think from my side, it's all done. Thank you very much. Dr. Jayesh Bhai, you would like to say something?
More experience, I would say that we discussed that irradiated washed RBC should be there for intrauterine transfusion, but in some of the rural India where some of my fetal medicine friends are practicing, if not available, they do O-negative transfusion, taking risk of host versus graft reaction.
True, sir.
That is also working.
Yes, I mean
it doesn't happen in everyone.
True. Yes. Best if available,
Best is
right?
fine. Yeah. Okay, we can conclude now, Darshan. Yeah.
Yes, sir. So once again, thank you very much, everyone. Also, TOG Science Integra for this session, and would like to thank Dr. Jayesh Bhai, Dr. Itanshu, Dr. Bhavesh Bhai, Dr. Paras Bhai, and Dr. Deepa Bhai for coming up and sharing their knowledge and experience with us.
Thank you so much.
Thank you very much.
To all.
Bye, all of you.
Bye.
Bye.
Thanks to Dr. Punjabi also.
Yes, Dr. Punjabi also. Very much. I couldn't see it. Sorry.
Okay.
Thank you. Bye,
Okay.
sir.